and a very warm welcome on the second day of Oncology Insights. And with immense pleasure, I would like to invite Dr. Navdeep Singh, who is consultant medical oncologist at American Oncology Institute, Jalandhar, for the welcome and introductory note. Over to you, sir.
Very good evening to all, and I welcome all for the second day of this virtual conference. Today I'll start with the session as Dr. Rahul has person, but he's not available. Can someone share the slides, please, of first session?
Yes, sir, I'm just sharing the slides.
Yeah.
Sir, slides are visible.
Yeah. Topic of discussion is systemic therapy combination for early or intermediate stage SCC, and we will discuss current evidence and what are the ongoing trials. The discussion is important because most of the time, this is a gray area where we don't have any strong evidence. So I'll start with my talk. So this is again a BCLC staging and treatment strategy for SCC. We know for very early stage there is option of ablation and resection, and for the early stage CTPA to be a patient having good performance status and a solitary lesion, there could be there is surgical option is there, and the patient having 2 to 3 reduce which are less than 3 centimeter has an optimum candidate can go for a liver transplant also. For the intermediate stage, we have the options of chemoembolization and ablation, in which various local therapies can be used. And for the intermediate stage is the one of the most heterogeneous group where a lot of treatment options has been discussed and the trials are ongoing. And again, in the advanced stage or a terminal stage patients, if the patient is having good performance status, child to get the role of systemic therapy is there, in which we can combine immunotherapy with the targeted therapy. And in the end state terminal state patient or CPC, most of the time it's only the best supportive care which has to be given. Next slide, please. The point is that whenever we do surgery for SCC or the resection is there, we don't have any actually very good data what to be given in adjuvant treatment or what to be given as a new adjuvant therapies. You can see the cumulative incidence of recurrence that increases as the time passes by. It increases every year. So there is definitely a need of some new adjuvant treatment in the locally advanced cases or some adjuvant therapy in some high risk cases. Next slide, please. This was a strong phase 3 trial in which they did give adjuvant sorafenib, and which was compared with the placebo after SCC resection or ablation. There was not much benefit given with the sorafenib. As you can see, the recurrence-free survival was almost same, the hazard ratio of 0.9. So still there is an unmet need of some definitive treatment. Next slide, please. Okay, so what is the current guidance? Because there are again there are high recurrence rates in the SCC. So there are different organizations like ASLD. It recommends against the routine use of adjuvant therapy. They don't recommend the adjuvant therapy as to as there is no clear-cut data. Again, ESL also against they again say that the new adjuvant or adjuvant therapy are not routinely recommended. But yes, they can improve the outcome of the patient if they are treated with their section. And NCCN again it doesn't recommend the use of any adjuvant therapy. Next slide, please. So this was a trial in which the locally advanced SCC patients were taken. It was a phase one study in which the immunotherapy nivolumab was combined with cabozantinib in the patient with the locally advanced SCC. And around 15 patients were enrolled, and in out of the 15, 14 underwent for surgical evaluation, and in the 13 surgery were attempted, and the five patients had a major or a complete pathological response, and most of the patient had a stable disease with one partial response. Next slide, please. So, and again, there was another phase two study in which they used perioperative combination of Nevo plus CP. And the patient, baseline patients were again, they were the patient having HCC, which were eligible for surgical section. Major pathological responses were seen in few patients, and pathological complete response was again seen in few patients in both the groups. Still, so again, the data was not that convincing, but yes, the few patients had a pathological complete response. Next slide, please. So these are the multiple trials which are ongoing, in which the various combination of immunotherapy and the combi with targeted therapy anti-angiogenic drugs like bevacizumab is being studied. The common are the IMRL2 and IMBRAVE 050. Next slide, please. So in the IM Brave 050, in the high risk SCC patient, they are studying the role of adjuvant atezolizumab plus bevacizumab. Again, the patient who are newly diagnosed SCC after curative section of ablation, and if the patient is having underlying childhood gap with a good performance status and no residual disease, they are randomized to the this standard ATBEV regime, which we use in even in the advanced SCC. And the primary endpoint is recurrence-free survival, and the secondary endpoint again with the overall survival. Next slide, please. This trial is ongoing, results are awaited. This again trial, again the other trial MRL2, it's again studying the role of adjuvant durva with or without bevacizumab in the high risk patient who are having underlying good performance status with the initial CPC 5 or 6. There are three arms which are being studied: the combination of durva plus bev compared to the durva, and the third arm is the placebo. The again this endpoint being recurrence-free survival for durva plus placebo, and secondary endpoints recurrence-free survival for durva plus bevacizumab plus versus placebo. Next slide, please. Next slide, please. So we know that for the most of the patients in which they have a localized disease, there is always an option of local therapies like TACE and TARE. If you see, there are n number of studies which has been done for, with the TACE, and if you see the TACE definitely improves survival, but it doesn't remain to be curative option, and it has to be repeated in some patients also. If you see the survival again with the time, the survival decreases, and roughly around the survival decreases to 27% around 3 years. So yes, their taste is and also an option in intermediate stage SCC. But again, the point is that in most of the patient, the disease reoccurs. Next slide, please. So, and there are different categorization of the patient which are unsuitable for the taste procedure. So, when the patient become condition that easily become refractory, if the patient is having a score of CTP 7 and above, and in which again the condition in which the taste can cause deterioration in liver function to child plus B, if the CTP score is up, and if the modified LB grade 2B, and the patient condition in which the patient unlikely to respond to taste. If the patient is having a nodular tumor with some extranodular growth, multinodular tumor, if the tumor is massive, and if the SCC is poorly differentiated, if the patient is having underlying multifocal mets, if the again and the if the due to taste, this there could be underlying sarcomatous change. Next slide, please. In this study, there was a study in which the patient with the larger intermediate stage SCC, they combined the conventional treatment of TACE versus the lenvatinib. If you see the median PFS, although was it was better with the lenvatinib, and in the median OS was also better in this subgroup of intermediate large SCC, with the hazards ratio were favoring the lenvatinib arm, and the overall response rates are also better with the Lenva as compared to the TACE. Next slide, please. This study, again, the combination of this ATBEV was tried as the versus the TACE for the intermediate stage at SCC, and the results are still awaited in which the ATBEV combination is being compared to the TACE or DEP-TACE, and let's see what the results come. Next slide, please. There is another trial in which sorafenib or placebo plus the DEP paste was compared. The patient who in which the DEP paste was done because the addition of sorafenib was done versus placebo. They were both compared, and still the median was in the end was moderate, and time to progression is still comparable in both the arms with a hazard ratio of only 0.79. Next slide, please. The one thing is the abscopal effect. It is basically the effect in which if you do some local therapy of a tumor, like if we go for a radiation of the tumor cell, due to the abscopal effect, the body immune response will get, and there is also a systemic response which develops. Again, with the local therapy, the body also has some systemic response to the tumor also. Next slide, please. So these are the different ongoing trials in which the combination of the different drugs like immunotherapies, either a single agent or a dual, or even with the targeted therapy combined with the TACE, and they are being compared with the TACE alone. Next slide, please. Just to summarize the things, we know the surgical section it offers a long-term survival. We most of the time we say that the surgical section is the best treatment which what a SCC patient can get. But again, there are always a chances of high recurrence is there. Yes, adjuvant therapy, there is not much data, but yes, TKI is the might benefit, but otherwise not a convincing data of this thing. So the trials are being done with the adjuvant therapies and checkpoint inhibitors. So the local regional therapies, they definitely prolong survival in patients with the BCLC stage B SCC. So we have to again we recognize have to recognize the patient which are taste unsuitable or a taste failure. So we have to go with the systemic therapy in such patient. And there are now we have a lot of trials going in SCC in which the combination of immune checkpoint inhibitors along with the targeted therapy anti-angiogenic agents plus the taste and local therapy they are being combined to so that we can provide maximum benefit to these subgroup of patients. Thank you.
Thank you, sir. Thank you for the excellent talk. And as we move forward, support team, I request you to close the recording.
Please start, ma'am.
Thank you. So, as we move forward for the session 2 on genitourinary cancers, the sponsored session by Dr. Reddy. For this, I would like to invite Dr. Kanupriya Bhatia, Medical Oncology at Ludhiana, for a talk on efficacy and safety of darolutamide plus ADT in patients with MHSPC from the phase 3 ARNOT trial. Over to you.
Good evening, Dr. Kanupriya.
Good evening, Dr. Navdeep. And first, I would like to thank Dr. Navdeep and the academic partners for allowing me the opportunity to talk on a drug which is upcoming in prostate cancer. I would be I would be discussing the Aeronaut trial, and I'll just share my slides. Are my slides visible?
Yes, ma'am. Just
Yes.
make it full screen.
Yeah,
Mhm.
I'm doing. So yeah, good evening once again. So I would be discussing the efficacy and safety of darolutamide plus androgen deprivation therapy in patients with metastatic castrate-sensitive prostate cancer. And this is the phase 3 ARANOTE trial. The data was discussed in ESMO last year, and then the trial got published in JCO last year. So before I go on to what the paper was all about, I'll just briefly tell what the treatment algorithms, what the options are for metastatic castrate-sensitive prostate cancer. So there are basically 9 approved indications on how we can treat these patients. Earlier, we used to just do androgen deprivation therapy. Then came the major Stampede and Latitude trial with so many arms and confusing data guiding us on how do we proceed. So Stampede data compared the addition of abiraterone to androgen deprivation therapy versus placebo plus just ADT alone, and we saw that there was a survival gain of almost 3 years with a hazard ratio of 0.6. Similar data was seen with the Latitude trial also. Then similar to abiraterone, enzalutamide came into the picture. Enzamet trial got published. Enzamet showed that adding Enza along with ADT again improved the progression-free survival as well, and there was an OS benefit. And we can see that the OS hazard ratios all fall around zero point 0.6 in all of these trials. So then the newer molecule apalutamide came, the Titan trial was there, which again had similar results. So all these 4 trials that I tell you, they tell us that addition of an androgen receptor pathway inhibitor, that is an RP, when it is added over and above ADT, we are getting a better overall survival. Now, along with that, there were parallel trials. There were arms of Stampede, which added docetaxel to ADT, and there was a benefit of adding chemotherapy also, especially in patients who had a high volume disease. So in Stampede, we saw that when we are adding docetaxel, OS is improving and hazard ratio of around 0.7 is there. It was better in high volume disease. Again, Charted had similar result. And then people thought that maybe we combine both RPs and docetaxel, and that is when the Peace One and Arasens trial came into picture. Peace One showed that when in patients, especially with high volume disease, you are adding both RPs and docetaxel along with ADT, you get a better progression-free survival and OS. And similar thing with the darolutamide molecule we saw with an Arasens also. So before I discuss the trial in question today, these were all the data that were already available in this setting. It's not a setting that was new to us, but this trial, ARANOTE, is giving one more option in our armamentarium, which we can use up in our patients with CSPC. So basically, metastatic CRPC, what we know till now is ADT alone is inferior. We need to either add an RP plus minus a chemotherapy, a taxane. So this is the trial, darolutamide in combination with ADT in upfront metastatic CSPC patients. So it was an international study done over 15 countries, a randomized double-blind placebo-controlled study where all patients of castrate-sensitive prostate cancer, performance status 0 to 2 were taken, and a 2:1 randomization was done into either receiving darolutamide 600 milligram twice a day or just a placebo along with ADT. The primary endpoint of the trial, like many other prostate trials, was a radiological progression-free survival, and the secondary endpoints included overall survival, time to initiation of the next line of therapy, time to becoming CRPC, to PSA progression, rates of undetectable PSA, time to progression of pain, and the safety profile of the drug. So these are the participants. What we can see, around 650 patients, they took part in this trial. And what is to be noted here is that around 50% of the patients actually belong to a low middle income country. They had taken patients from Asia, they had taken from Africa and Latin America as well. And the other point which is important here is they also took performance status 2 patients, which we very commonly see, in fact, 3 and 4 in our metastatic CSPCs. And the disease volume in 70% of the patients, according to the charted criteria, was high. So this is the progression-free survival, which we see the curves are very well separating. Darolutamide, in addition to ADT, has reduced the risk of radiological progression. At around 2 years, we see 70% of the patients on darolutamide have not progressed as compared to those receiving placebo only with ADT, and the hazard ratio is 0.54, highly significant. when they discussed the data in ESMO last year, they had followed up the patient for almost 2 years when they discussed the results. So when we see the forest plot, we can see that almost all categories, all stratification that they had done, addition of darolutamide, as is expected, helped these patients. What is to be seen here is that the hazard ratios in low volume disease is 0.3, much more better than in high volume disease. So additionally, when you're adding darolutamide, the time to PSA progression also, there is a very good separation of the curves. And the decrease in the PSA is also more when you add darolutamide along with ADT. The secondary outcomes of the trial, all of them actually, they were immature to actually discuss. But the forest graph, we can see that all favor, be it the time to progression to CRPC or PSA increase or pain progression, all favor the addition of darolutamide. So coming to the safety profile of the drug, they say, I have not personally used, the drug is not available. It's just started to being available, but very expensive in India yet. But what we know from the studies that we have read and people that are discussing, that it's a very easy drug to tolerate with very mild and minimal side effects. We can see that the common ones are anemia and arthralgia. And one interesting thing is, if we see down below, there is a side effect of fatigue, which is more common with placebo as compared to the addition of darolutamide. Fatigue, we all know ADT is cause much fatigue. So probably here, it might be because the disease control is much better with addition of darolutamide. So the fatigue due to disease actually decreases, which is why there is a difference here. So these were all the good things of the trial. Now let us come on to the trial was much in was caught up in controversies because of the inferior the control arm, which was inferior. Like I told you before, the beginning of before the trial actually started enrolling, we already had data from Stampede, from Latitude, and from Charted trial, where the addition of something, either chemo or RP with ADT, was already out. So here, the patient in the control arm were just receiving ADT. So people have criticized the principal investigators that the inferior arm, sorry, the control arm was actually inferior in this trial. So the control arm was suboptimal to begin with. Standard of care, we know, was different when the trial started enrolling. Addition of docetaxel, like I said, or of abiraterone had already been approved in all of these trials. So on the flip side, what we can see is that we actually, though when we are discussing in a metastatic patient, what matters most is actually the overall survival. But if we talk about it with the patients who are getting the treatment, it's not only the survival that they are looking for. Our patients want minimizing pain and the other symptoms associated with the disease. They want to be independent. They want to have a good quality of life, especially patients when they see a tumor marker. Reading PET scan and all is difficult, but PSA, the patient very well understand because they have a report of PSA. So the PSA goes from 4 to 8, the patient can very well see. So they want to control their PSA and they want to avoid treatment related adverse events. So all these things, when we are adding chemotherapy, maybe docetaxel or something, the side effects increases. The patient has to come to the hospital. So it's not only the survival curves which are always important. We also have to see what the patient wants from the treating doctor. So on that note, there is a newer data of the Aranote, which was discussed just as a week back in ASCO this year. They also assessed the pain and the quality of life of the trial, and the pain assessment score that they used was the BPI score. Along with that, they also calculated the FACT-P score, which was seeing what was the physical well-being of the patient, what was the social, emotional, functional, and what were the symptoms due to the prostate cancer itself, like bowel and urinary difficulties. And they all saw that when you are adding darolutamide, the time to pain progression, as is expected, it increases. And the FACT-P deterioration, the time to that deterioration also increases. So darolutamide is actually helping in all the aspects of the FACT-P score. The patients feel that they are more independent. They don't have to come to the doctor again. It's just an oral drug that they have to take, and they are emotionally well as well. So darolutamide actually is the only RP which has scientifically shown delay in pain progression and an overall well-being. So though the drug is associated with the trial is associated with one of the very major shortcomings, but the data actually gives us one more option that we can eventually someday in the future offer to our patients who want a therapy for their CSPC, which is not very toxic and is uh, more easier to take as well. Thank you.
Thank you, Dr. Kanupriya. Just want to ask, so how commonly you add chemotherapy in your patients? How easy to convince them, or a specific subgroup in only in high volume disease you'd like to add?
So I add only in high volume disease, and that too if the performance status allows me to, because
Okay.
many of the times the high volume disease, the performance status is also very bad. So only if the performance status is 1 or maybe borderline 2, then I add. Otherwise, I usually only start with ADT and add abiraterone usually with
Okay.
it.
So you mostly cases you start with the Biratron and then you.
Yes, sir.
Okay. Thank you.
Yes.
Thank you, Dr.
Okay.
Kanupriya.
Thank you, sir.
Thank you, ma'am. Thank you for the excellent.
Thank you for the excellent talk. Next, I would like to invite Dr. Karika Sharma. She is considered medical oncologist at Max Hospital, Mohali. Dr. Kanika, the stage is yours on.
Yeah. Hi,
Good
everyone.
evening, Dr. Kanika.
Good evening. Are my slides visible?
Yes, sir, ma'am, it is visible. Just make it full screen. Perfect. Thank you.
Just- Okay. Please, yeah. So, good evening, everyone. I've been assigned the topic of radium 223 along with enzalutamide. That is the Peace 3 study that was done. It was basically the addition of radium 223 in asymptomatic or mildly symptomatic patients with bone metastatic castration-resistant prostate cancers. So a little bit of background of this combination. So as we all know that abiraterone and enzalutamide, they are the standard of care options for the first line treatment. And the patients who progresses with the androgen deprivation therapy. So we commonly use these patients who don't have a high burden disease and in which we don't want to add chemotherapy for these patients. So radium 223 is an alpha particle emitting calcium mimetic that selectively targets the bone metastasis and induces the double strand DNA breaks. So there were previous studies as well that have combined use this combination. So like in El Simca trial, the radium 223 they have improved overall survival in patients prior to the introduction of abiraterone and enzalutamide. But after that, there was a trial that is the ERA trial in which the patients who were previously tested the combination of abiraterone plus radium combination versus abiraterone alone. But actually, this combination was detrimental when used in the combination. So not only did this combination increases the fracture incidence in the subjected arms, also there was no statistically significant difference in the survival in the patients who received this combinations. So upon this background, they come up with this EORTC-based Peace 3 study that is a prospective phase 3 trial in which they have taken metastatic CRPC patients with bone metastasis who were asymptomatic or mildly symptomatic. So this is a major chunk of the patient in our OPD also, and around 70% of the patients also present to us in the stage 4 disease with the bone-only disease. So in the when we talk about the eligible patient, no prior enzalutamide or radium and no known visceral metastasis. So it should not be in high burden disease. Patient should not be symptomatic for the bone metastasis. And prior treatment with abiraterone and docetaxel was permissible in the hormone sensitive settings. So they have used 1:1 randomization. So the experimental arm have taken the radium as 55 kbq per kg IV every 4 weeks for the 6 cycles, along with the standard dose of abiraterone, that is the 160 mg once daily, and the control arm include only enzalutamide. So the primary endpoint was the radiographic progression-free survival, and the secondary endpoint that they have included were the safety, overall survival, time to next treatment, time to pain progression, and time to the first symptomatic skeletal events. So coming to the study design, again, giving the increased rate of fractures that were reported in the previous combination study, that is the ERA 223 trial. So there was a study amendment that was made in these patients that mandate the use of a bone protective agent and also a baseline DEXA scan that have to be done in these patients prior to enrollment. So they have taken patients with metastatic CRPC and bone metastasis, asymptomatic or mildly symptomatic, who have a performance status of 0 or 1 with no prior treatment with enzalutamide or radium, no known visceral metastasis, and ongoing ADT. So they have taken total of 446 patients and randomized them into 1:1 ratio. So again, a combination arm or a single enzalutamide arm. And they have stratified based on country, what is the baseline pain, that was the BPI worst pain from 0 to 1 versus 2 to 3, whether patient have received prior docetaxel or bone protective agent, and whether patient have used prior abiraterone. So primary endpoint was radiographic progression-free survival. And the key secondary endpoint, as we have discussed earlier also, was the survival, time to next treatment, pain progression, and the symptomatic skeletal events. But because of the ERA trial, in this, the bone protective agent, they were made mandatory after the initial inclusion of 119 patients. So between November 2015 and March 23, so around 8 years of inclusion, so 446 patients were enrolled from 12 countries, and the median follow-up was 42.4 months. When we talk about the baseline characteristic, as they are usually a disease of elderly, so the median age was 70 years in both the arms. The median PSA was around 25. With the performance status 0 in majority of the patients, the 70% of the patients, they have PS 0 with no complaints as such. Around 30% of the patients, they have received prior docetaxel, and around 2 and 3% respectively have received prior abiraterone in these settings. When we talk about the bony lesions, around all the patients, they have bony lesions, and half of the patients, they have more than 10 bony lesions. So a lot of bone disease was there at the baseline. When we talk about the higher alkaline phosphatase, it was seen in 50% in the enzalutamide and in the combination 37. And the extraskeletal disease at baseline was in around 33 to 35% of the patients in both the arms. So when we talk about the So of the 222 patients in the combination arm, 97% they received both the treatments. So the treatment compliance and the completion was good in this arm. Of the patients who received the radium, 88% they completed all the 6 planned cycles. So when we talk about both the arms, so the enzalutamide treatment duration, in months was around 17.3 months, and the 14 months in the single arm. So it was more actually in the combination arm as compared to single. And when we talk about the radium number of cycles, the patients, around 88%, they complete all the 6 cycles, and hardly 11% of them would receive less than 6 cycles. So the addition of radium to enzalutamide was associated with a significant improvement in the primary endpoint of the radiographic progression-free survival. So as we can see the graph here, So when we talk about the 24 months, at the 2 years progression-free survival, it was 36% in the single arm, that is the enzalutamide alone arm, versus 45% in the combination arm. And when we talk about the median PFS, it was 19.4 versus 16.4 months with a significant hazard ratio of 0.69. So when we talk about the forest plot also, so all the arms, they have shown consistent benefit that have favored the combination therapy. So as these analyses, they are exploratory, so no adjustment for multiplicity was considered. And we can see whether it was the baseline pain score, the patients who have more actually pain score, they benefited more with the combination therapy. Again, when we talk about the prior therapy, again, the tolerance was, tolerance was better in the patients who have not received the prior docetaxel administration as compared to the patients who have received. And the BPA safety letter, again, after it was improved, the age in the patients who were less than 75, there was a benefit as compared to more than 75 years of age with a performance status of 0. But overall, all the subpopulation, they benefited with the combination approach. So there was an overall survival benefit was also observed in the combination arm. So as we can see, there was initial overlapping, but we can see after even around 4 years after treatment also, there was a significant separation of the graph between the two therapies. And when we talk about the median OS in both the arms, the combination, it was 42.3 months as compared to 35 months in the enzalutamide alone arm. So, yeah, when we talk about the other secondary parameter, that is the time to next treatment, as we can see that the 22 years time to next treatment, it was needed in around half of the patients in the enzalutamide alone arm versus only 30% in the combination arm. So again, the hazard ratio was significant, 0.57. And the at 24 months, the when we talk about the estimate of the proportion start in next systemic treatment, it was 29.9 versus 50.9. So again, there was a significant difference. So patients were controlled, have the controlled disease in the combination arm for a longer period of time. Again, the symptomatic skeletal event, it was as such same between the both the arms. When we talk about that is the 18%, but the number of no or the fracture when we talk about it was also. So as seen in the ERA trial, there was no significant increase in the fracture rate that was seen in the combination arm in this study. So coming to the safety of the combination arm, again, the adverse effects were almost similar, but yes, grade 3 to 5 drug-related adverse events were slightly higher in the radium arm as compared to the alone arm. Death were again comparable, that was 7 versus 4 in both the arms, and the treatment discontinuation when we talk about due to toxicity, it was seen only in the 7 patients because of the radium and 13 patients in the enzalutamide because of the enzalutamide tolerability. So the most common grade 3 to 5 treatment related adverse events were that were seen. So the hypertension, again, it was comparable between the both the arms. The fatigue was slightly higher, as we all know that with the radium, that also enzalutamide is known to cause fatigue, and the addition of radium then enhances that side effect along with the fracture risk. So that was 5% versus 1.3%. Anemia was slightly higher as the neutropenia. So these factors we have to closely look upon in the patients who were receiving the combination therapy. So summarizing this Peace Tree trial, the combination of enzalutamide and 6 cycles of radium every 4 weekly, they showed a statistically significant improvement in the radiographic progression-free survival. And the median radiographic progression-free survival, it increased from 16.4 months with enzalutamide to 19.4 months in the combination arm. And it was also supported by a significantly improved overall survival that has a hazard ratio of 0.69. But due to the non-proportional hazard, this will be tested further in the final survival analysis to confirm this survival data. Also, there was the improvement is supported by a statistically significant time to next systemic treatment. As we know that there are, after the initial 2 to 3 options, we are hardly out of the options in the patients with prostate cancer, like with docetaxel, lebrotron, the cabazitaxel. Very few patients can actually tolerate the cabazitaxel in the subsequent line of the treatment. So the drug-related more than grade 3 adverse event, they increased from 19% to 28% in the combination arm. So these results support the combination of enzalutamide plus radium plus bone protective agent as was amended in the protocol as a potential new first-line treatment option for the patients who have a bone-only disease and who have not received a prior androgen receptor pathway inhibitor. Thank you.
Thank you, ma'am. I just want to ask, did they use some bone modifying agents in the control arm?
Yes, they have used both ADT as well as a bone modifying agent in this, along with the combination.
What could be the reason of prolonged survival with this addition of radium?
Maybe, see, one is the added benefit of radium also. So as we know that the main disease is in the bones only. So when we target them, the, further quality of life also improves, and that may have affected the overall prognosis also in this case.
Okay, thank you. Thank you so much, ma'am.
Thank you, Dr. Kanika, for your excellent talk. Now, moving forward, I would like to invite Dr. Abhinav Narvaria, considered medical oncologist at Manipal Hospital, Delhi. Over to you, Dr. Abhinav.
Good evening, sir.
Good evening. My slides are visible?
Yes, sir, they are.
Just a second. ये नीचे ऐसा होता है. Okay. So, thank you, Dr. Navdeep, for inviting me. And today I'll be speaking on efficacy of lutetium therapy in PSMA positive metastatic castrate-resistant prostate cancer following regression on an androgen receptor pathway inhibitor. So this was a study presented in ESMO 2024. As we all know that in metastatic CRPC, we are short of drugs, and sometimes patients who do not respond on androgen receptor blockers or chemotherapy, we are looking for options, and lutetium-177 therapy has proved to be, of very useful, and patients do respond to it, especially patients who are having high burden of disease in bones. So, background, metastatic CRPC has limited treatment options after progression of androgen receptor pathway inhibitors, and PSMA is always a promising target for radioligand therapy in this setting. So study objective was to evaluate the efficacy and safety of lutetium-177 compared with androgen receptor pathway inhibitor in PSMA positive metastatic CRPC following progression on prior ARPI therapy. So we all know, patients who have progressed on androgen receptor pathway inhibitor therapy, we are short of drugs, and chemotherapy is always the option, and sometimes we have already used chemotherapy. So, and we have very less chances that patient who have progressed on one inhibitor will respond to another. So we are always looking for option, and lutetium-177 therapy is a fair option. So this is a study design, phase 3 SPLASH trial, which was a randomized multi-center open label study, patient with PSMA positive metastatic CRPC post ARPI treatment. Primary endpoint was radiographic progression-free survival. Secondary endpoints were PSA response, overall survival, and safety. So patient demographics were baseline characteristics were balanced across the treatment arm. Median age was 71 years. ECOG PS01. Prior patients who have received androgen receptor pathway inhibitor therapy were 100%. Prior chemotherapy not allowed. So I think in this patients who have received docetaxel in castration sensitive setting were allowed. Patients who have received the chemotherapy in CRPC setting were not allowed. So most of the patients have already exhausted androgen receptor pathway inhibitor therapy. So these were the and you can see the median is 71 years. And one important point is that that patients with ECOG PS01 were only allowed in this study, because taking lutetium 177 is not very, there are many side effects. So treatment protocol was that experimental arm had they were given 4 doses of lutetium 177 therapy every 8 weeks, and control arm was alternate androgen receptor pathway inhibitor. So if you have taken enzalutamide, you will get abiraterone, or if you have taken abiraterone, then you'll get enzalutamide. And most of the patient, the crossover was allowed. So patients who have progressed on another ARPI were allowed to take lutetium 177 therapy. So primary endpoint was radiographic progression-free survival. So you can see the lutetium 177 has significantly improved the radiographic progression-free survival. So median radiographic progression-free survival was 9.5 months versus 6.0 months, and with an impressive HR of 0.63. Radiographic progression-free survival was benefit was observed across all the key subgroups. I think I am not having that subgroup analysis forest plot, but most of the patients benefited across all the subgroups. More patients were benefited who had more of more who had more high levels of PSA, who were I think uh, I have to see the forest plot, but yes, the more the PSA was, more patients were benefited from lutetium 177 therapy. Secondary endpoints were PSA response rate more than 50%. So it was 36.5 versus 17.2%. Median time to symptomatic progression was 12.3 versus 7.5 months. At the time of interim analysis, overall OS data was not mature. So if you see, the time to symptomatic progression is around 1 year versus 7.5 months. That is very impressive in a setting of metastatic CRPC, where patient is going to become symptomatic with severe bony pains and neuropathic pains. Talking about safety and tolerability of lutetium 177, so it is very well tolerated. Grade 3 treatment related adverse effects were 36 versus 27. Most common, as we all see in our practice, is fatigue, dry mouth, and nausea. I think grade 3, 4 adverse effects were only to the tune of 4 to 5%, if what may it be fatigue or dry mouth or nausea. There were few treatment discontinuations due to adverse effects. So coming on the conclusion, lutetium 177 therapy has demonstrated a clinically meaningful radiographic progression-free survival improvement over the androgen receptor pathway inhibitor in PSMA positive metastatic CRPC, and the favorable safety profile supports its use in the earlier treatment line. We all have been using it later in the treatment line, post chemotherapy, post 2 to 3 lines of ARPI. But this data suggests that if you have a patient with heavy disease burden, a lot of bone metastasis is there, so you can refer them to your nuclear medicine colleagues for lutetium 177 therapy earlier in the treatment path. So lutetium 177 is an effective and tolerable treatment for PSMA positive metastatic CRPC post ARPI failure, and it supports a potential integration into standard treatment algorithms. Thank you.
Thank you, Dr. Abhinay. Dr. Abhinay, how many cycles do normally your patients take for the response to get two, three,
So,
four?
Dr. Navdeep, if I talk about, response, patient starts symptomatically improving even after one cycle, but
Hmm.
generally we try to complete 4 cycles. If patients, do not, if the patient response is good and there are side effects which are considered to be, hampering the lifestyle, then we can stop after discussion with the with nuclear medicine colleague. But I think 4 cycles should be given. Generally, patients start improving within first to second cycles, and the duration between the 2 cycles is quite large. So patients do improve after the side effects.
So we don't have only one center in Chandigarh, I think is going, but we don't regularly do. But just
I
tell me
I
one
cannot
thing.
listen to you properly, boss.
Yeah, just want to know one thing in prostate with neuroendocrine differentiation, post progression on chemotherapy, you are getting in these patients also radiation therapy.
I prefer for patients who are, PSMA positive and, the PSMA PET scan is shining like anything. I am not very sure about the neuroendocrine differentiated tumors.
Okay, thank you, Dr. Abhinav. Thank you
Thank you,
for
boss. Thank you.
Thank you, sir. Thank you for excellent talk. And as we move forward, I would like to invite Dr. Sushant Mittal, who is consultant medical oncologist at Action Cancer Hospital, Delhi, for the talk on clinical updates from ESCO 2025. Over to you, sir.
Good evening,
Thank
sir.
you.
Thank you for your time.
Good evening, Navdeep. Thank you for the invitation. And can somebody run my slides?
Just a moment, I'm just sharing the slide, sir.
Yeah. So the topic given to me is ASCO updates 2025. There are many updates, but I'll be discussing about two trials which are, I feel, are practice changing. Next slide. First one is Serena 6. It's a phase 3 trial of ctDNA guided switch to camizestrant plus CDK4/6 versus continued of AI plus CDK4/6 inhibitors following an ESR1 mutation emergence in hormone positive advanced breast cancer. Next slide. We all know that ESR1 is an uncommon mutation leading to progression in hormone positive advanced breast cancer, and it is tested by hotspot ESR1 leading to a constitutive activation of ER. This mutation can also be detected by ctDNA liquid biopsy 6 months prior to the clinical progression. And I should remind you that this is not a baseline mutation, it is an acquired mutation which emerges during the treatment natural history of the patient. PADA-1 trial showed that switching to fulvestrant plus Palbo upon ESR1 detection in ctDNA ahead of disease progression significantly improved PFS versus continuing AI or Palbo. So camizestrant is an oral SERD designated to inhibit and degrade both wild and mutant ER, and current analysis tested to hypothesis has been done in this trial. Next slide. Next slide, please. So this was the study design. Patient with hormone positive advanced breast cancer who have received more than 6 months of first line AI or CDK6 inhibitor detected to have ctDNA ESR mutant with no evidence of disease progression. They were given camizestrant along with CDK4/6 inhibitor and AI versus continuation of CDK4/6 and placebo, and the disease progression up to unacceptable toxicity was the endpoint. The primary endpoint being PFS and secondary being PFS2, overall survival, safety, and PRO. Next slide. And as the graphs are speaking for themselves, we can see that the median PFS has reached up to 16 versus 9.2, which is significant in this category of patients who have yet to progress on PET scan or yet to progress symptomatically. So we are able to catch them at early stage, and the graphs are separating initially only much more before 3 months. Next slide. So subgroup analysis, this is a subgroup analysis which shows that the hazard ratio is quite significant in all category of patients, in all ethnicity of the patients, and whether it has been started less than 18 months or more than 18 months, or irrespective of the CDK4/6 inhibitor used. Next slide. So they concluded in Serena that switching from AI CDK4/6, addition of camizestrant had a significant improvement in PFS when at molecular level ESR1 with ctDNA is detected. It is a well-tolerated drug with a low rate of treatment discontinuation, and this might be a practice-changing drug in coming few months. Next slide. The second trial being Ascent-04, Keynote D19, a phase 3 trial for the first line Satizumab Govictan plus Pembro versus chemo-pembro in PD-L1 positive advanced TNBC. Next slide. We all know that in 40% of the patient of TNBC, they are PD-L1 more than 10, and the standard of regimen is chemotherapy plus immunotherapy. Satizumab is a TROP2 directed ADC, FDA approved in patient with either locally advanced metastatic TNBC after more than 2 prior lines of therapy, or in first line metastatic setting, or hormone positive patients after ET or more than 2 additional treatment in metastatic setting. Research have suggested that there is a synergistic effect between immunotherapy and ADC, resulting in better efficacy, and hence these two drugs were combined. Next slide. So again, it's a global, multicentric, randomized phase 3 trial. Patients who were previously untreated TNBC with PDL1 more than 10, Satizumab plus Pembro versus chemo plus Pembro, and the primary endpoint was PFS, secondary endpoint was OS. Next slide. So the PFS at 6 months, the median PFS is 11.2 versus 7.8. 6-month PFS is 72 versus 63, and 12 months PFS is 48 versus 33. And as the time is evolving, the graphs are separating, and the combination of these two drugs have given a PFS benefit. Next slide. It's a well-tolerated drug. The treatment discontinuation rate was similar in both the arms, although we have very less first-hand experience of using SG, but this trial data and the side effects profile suggest that it can be used in this category of patients. The median duration was 8.9, but in Pembro it was 8.5, and the median duration of CT was just 6.2. Next slide. So again, they concluded that combination of ADC with ICI demonstrated a significantly improved PFS The median PF was 11.2 versus 7.8, higher overall response rate, and more durable of responses with SG and Pembro. Mature OS data is awaited. No new safety signals were noted. Hence, this is a potential new combination for PDL1 positive TNBC. Thank you so much for your patient hearing. The house is open for the discussion. Back to the organizers.
Thank you so much, sir. We are always short of options in TNBC. This might open up a new space in TNBC subgroup, sir. Thank you, sir. Thank you so much.
Thank you. Thank you. All the best.
Hello. Yeah, thank you, sir. Thank you for the excellent talk. So I would like to invite Dr. Navdeep for the concluding remarks. Over to you. Over
So
to
I
you,
would
sir.
like to thank you. I would like to thank you all the organizers for this wonderful conducted two-day conference, virtual conference, and all the speakers. Yeah, we'll keep on discussing things till the next meeting. Thank you all.
Thank you for joining us for Oncology Insight 2025. Over the last 2 years, we had a discussion on lung, breast, hepatomegaly, and GU cancer. We sincerely thank our sponsor, Roche, Zydus, AstraZeneca, Dr. Reddy's, Intas, Emcure, Vembres, VDR, and Samarth Lifelines for their valuable support in making this event possible. Your participation and insight have truly added value. We look forward to more such meaningful engagement in the future. Thank you so much.
Thank you, Dhruv. Thank you, everyone. Good night, everyone.